Hi, and thank you for joining me for this lecture on thoracic trauma. So, when we look at the thorax, again, to understand injury, we have to first understand the anatomy and a bit of the physiology of what we're talking about. So, we're just going to kind of go over the anatomy and physiology of the chest a little bit. Now, keep in mind that when we look at the, let me use a little different color here. When we look at the ribs, now neurovascular bundles, that's nerves and vessels, they lie right under the lowest margin of each rib. So on the bottom of each rib we would see this bundle of nerves and vessels, both arteries and veins. Now the pleura covers each lung and the thoracic cavity. Let's take a little closer look. So when we look in the anterior here, we see the ribs that go along, and it comes around into the costal cartilage. Now these costal cartilages attach to the sternum. And by the way, as people get older, these cartilages actually calcify. So in the elderly, when we make that first push down in CPR, you may actually feel or hear some cracking. What that is the breaking away of the costal cartilage away from the sternum. When we look at the diaphragm actually can come up to the 1, 2, 3, 4, way up here to the fourth intercostal space on exhalation. So keep that in mind too. Now, the linings, we talked about the linings just briefly. We have two layers. We have the visceral pleura, and the visceral pleura is actually that lining that lines tight against the lung itself. And then the inner lining of the thoracic cavity is the parietal pleura. When we look around in the back here, we see that the ribs are attached at different levels to the spinal column. We also have the scapula on each side. By the way, these move along with the shoulder, so they can move out when, say, a person crosses their arms, and when somebody arches their back, the scapula actually move towards the center. So keep in mind that if we have a rib injury, especially towards the back here, we may also have a spinal injury. This is just another look at the thoracic cavity and the whole cardiorespiratory system together. So we see, of course, the heart is located, and actually it is a little bit off to the left with the vessels coming out, the great vessels coming out. You have the superior vena cava and the inferior vena cava coming up, the diaphragm, and then the lungs on each side. These come up, and we see the carotid arteries here. Through here, let's use a little lighter color to see those. So we see the carotid arteries there, and subclavian arteries coming up here. Now, it's important here too to keep in mind that these are large arteries coming up here. So if you have any injury to, say, the clavicle or the first two ribs, you have a chance of severing these large vessels. We'll talk about vessel injuries later in the lecture. So when we discuss the mechanics of breathing, keep in mind that when the patient breathes in or inhales, the diaphragm goes down, the intercostal muscles and the ribs go up and out, and it causes a negative pressure inside the airways, which then brings air down into the lungs. Not quite that far. So down into the lungs. Keep in mind too that also kind of pushes down on the liver and the large intestines. Now, when we come over here and we have exhale, again, on exhale, the diaphragm goes up, the ribs and the intercostal muscles relax, and it's caused a positive pressure inside the airways that then push the air out. Now, then also you see that the liver and the large intestines, as the diaphragm relaxes, it has more room to live, if you will. So keep in mind that we have to have all this intact in order to have effective ventilation. Effective ventilation. Now, it's important to note that patients with a spinal injury below C5 can still breathe from the diaphragm. The diaphragm is still working. But patients with a spinal injury above C3, we're talking, when we talk C5, C3, we're talking about the cervical vertebra. So at the level of the fifth cervical vertebra and below, they can still breathe with their diaphragm. C3 and above knocks out their breathing. So that's something that we want to be really considerate of and be prepared to do bag valve ventilations on these patients. Now, minute volume, when we discuss minute volume, keep in mind that minute volume is normal tidal volume times the respiratory rate. So if we have a patient, the normal adult tidal volume, by the way, is 500 cc's or 500 milliliters. So if they're breathing 12 times a minute, then we know that their tidal volume is going to be about 6,000 cc's. And by the way, that's just a general rule. Now, a more accurate rule is to say 7 cc's per kilogram of ideal body weight. So I don't know, a 75 kilogram man, roughly about 150 pounds, times that by 7, that gives you your ideal tidal volume, and then we can figure it out from there. Now, patients with a decreased tidal volume tend to have an increased respiratory rate. Again, it's trying to get this ideal amount of air for the patient. So when the patient can't take full breaths, the body compensates by increasing respiratory rate. As we get ready to look at closed injuries of the chest, there's just some things that you have to remember. When you suspect a chest injury, you have to bare the thorax, the chest. But keep in mind that the chest is just not the anterior, it's also the posterior. We want to look for decap BTLS on both sides. And a good chest exam involves palpation. We're feeling for any crepitus. we're feeling for subcutaneous emphysema. I'll mention that when we get into tension pneumothorax in a little while. But we also want to listen. We want to listen to the lung sounds. We want to listen carefully. We also want to look at the integrity of the chest. So some things to keep in mind as we continue on through this lecture. Chest injuries, closed chest injuries, are generally caused by blunt trauma. Now keep in mind the underlying organs of the chest are important. A big, blunt, forced trauma can cause significant cardiac and pulmonary contusion. If the heart's damaged, it may not be able to refill with blood, or blood may not be pumped with enough force of the heart either to get the blood into the lungs with the bounce back to bring it back into the heart, or with enough ejection fraction, the amount of blood pushed out to go up into the aorta and supply the body. With lung tissue bruising can result in a huge loss of alveolar surface area. The air sacs can be damaged or filled with blood to where air can't get in for effective exchange of gases. And of course, rib fractures may cause further damage, either damage to the organs below, or their integrity isn't such that we can have a good negative pressure as the patient breathes in. So again, we have to remember that we have to have a good working diaphragm. Remember, the diaphragm can't get damaged. We have to have the integrity of all the ribs intact and the ability for the patient to breathe in. Now, by the way, keep in mind that the patient may have a decreased tidal volume and an increased respiratory rate just because of pain. Sometimes the pain gets bad enough on the patient that they don't want to take deep breaths. So they'll take smaller breaths against the pain or to the tolerance of pain and just compensate by increasing their rate. Open chest injuries occur whenever the integrity of the whole layer from the skin straight through past the ribs into the thoracic vault are compromised, and we actually have air that goes into the thoracic vault on inspiration. Now, in an open chest injury, an object penetrates the chest wall itself. So this would be something like a knife, a bullet, piece of metal, broken end of a fractured rib can also break that integrity and cause an open injury. If you have objects stuck in there, keep them in there. It helps seal the wound, believe it or not. So we want to just keep them in place, use bulky dressings, and then transport the patient. Now, when we talk, going back to blunt injuries to the chest may cause rib, sternum, and chest wall fractures, bruising on the lungs and heart, damage to the aorta. We talked about this already. Vital organs be torn from their attachment in the chest cavity. So let's look at the signs and symptoms. Pain at the site of injury. So localized pain that is aggravated or increased with breathing. So pain that increases on inspiration. Bruising to the chest wall. Again, make sure you look at the whole chest wall. Lift up the arms. Roll the patient to the side and look on the back. Be very careful and diligent in this. Crepitus with palpation of the chest. So as you palpate the chest, you can actually feel crepitus, that scraping a bone if you were crackling a bone. course, we're going to look for the penetrating injury of the chest, and of course, any dyspnea, any shortness of breath. Again, make sure you do lung sounds, listening carefully to both sides, comparing. Keep in mind to listen to all levels of the chest. Now, other things we want to consider: hemoptysis, which is coughing up of blood, failure of one or both sides of the chest to expand normally with inspiration. Now, keep in mind that if we have a patient that's had part of their lung removed for whatever reason, normally cancer, they may have an uneven chest rise. On your inspection, you normally see, these can't be taken out through arthroscopy. They have to actually open up the chest to do that. So you'd see surgical scarring. Certainly ask them if you have any doubts. They're going to have a rapid and weak pulse. We'll discuss how that works a lot, as well as low blood pressure and cyanosis around the lips or fingernails. As we said before, chest injury patients often have rapid and shallow breaths. It hurts to take a deep breath. The patient may not be moving air. Auscultate, again, the multiple locations, just not in the front and on the sides, but also in the back. Be diligent in your inspection and auscultation of the chest. Well, let's take a look at a pneumothorax. As we mentioned before, the lungs have two layers of covering: the visceral pleura that's attached to the meat of the lung, the parenchyma, and the outer lining that lines the inside of the lung. Now, over here we see that these normally move together in a potential space. So when a person breathes out, we don't see this spacing here. No, person breathes out, we still have a attachment between the visceral and parietal pleura, and it's sealed together with a liquid. Now, if we have a wound, we have a wound site here, then air can be introduced into the pleural space, separating this. So this potential space now becomes an actual space. And as air fills this up, it can become a tension pneumothorax. We'll talk about that in a little while. So in this x-ray here, what we're seeing is this black area over here. This is all air, and this here is the pleural line. This is where the actual lung is. So the lung is up here in this area, and air is in here. So when we compare that to the other side, you see here, you can see the vessels inside and some of the bronchi over in the fully inflated lung. Again, there's that potential space between the visceral and parietal pleura, to where that potential space on this side has become an actual space. So, most simple pneumothoraxes don't result in any major changes in the patient's cardiac physiology. We just have air in the lungs. A lot of these are simple. It's commonly due to blunt force that results in fractured ribs, but it can worsen and deteriorate into tension pneumothorax or develop complications. When we do the online lecture, I want to bring up a specific case of this development between simple and tension pneumothorax. Now you see here the open pneumothorax. when we have the opening to where air on inspiration, this actually becomes kind of a second airway, where on inspiration, air comes in, and on exhalation, air goes out. Now, the trouble with this is that a lot of the times, not all the air is pushed out on exhalation. So we actually have kind of a stair-step effect of air being introduced into the thoracic cavity and eventually causing a tension pneumothorax. And we'll talk about how to relieve that. It's actually fairly simple. So when we talk about the tension pneumothorax, we're actually seeing where air is coming in either from a closed or from an open, or both types of wounds. So as air is pushed in, it pushes against the heart and the other lung. So what this does is it causes the ability of the heart to refill to decrease. Now remember, it's referred to as Starling's law. The more the blood goes into the heart and stretches it out, the harder it's going to be pushed out. Well, when we have this actual pushing against the heart, reducing the amount of room, we decrease the cardiac stroke volume, the amount that's pumped out with each heartbeat, if you will, or heart contraction. So to compensate for that, the heart's going to beat faster. So we're going to see a tachycardia here. And what we'll see also is as it pushes over this way, we have a decreased ability for this lung to expand. So they'll decrease in tidal volume for the whole body, reduced oxygenation. And keep in mind, there's two sides of ventilation, air going in and air coming out. So we will get an increase in carbon dioxide, which of course is bad for the patient. In this x-ray, we're seeing where the pneumothorax is on this side in this picture here, and things are being pushed over. Now you're seeing just a little bit of tracheal deviation here. So on this side, you see a lot of tracheal deviation. So things are being pushed over. So again, what's going to happen? Again, the heart rate's going to go up. The heart isn't going to be able to fill, so it's going to back up. So if we back up from the right atrium, where the heart receives blood from the body, it's going to back up. So where we're going to see distended jugular veins. And also, when we see this, we know that the heart can't fill all the way, so we're not getting a full rest of the heart pressure, and we can't have a good, strong heart contraction. So we're going to have a decrease in systolic and an increase in diastolic pressure. And these are going to creep closer, and our pulse pressures are going to come together. So like 120/80, and then it's going to go to 100/86, and then 92/88. You see how these are getting closer together in number. And the difference between these two is your pulse pressure. Now, when we talk about flail chest, we have to consider the integrity of the rib cage. And remember, we need the rib cage to be intact in order to get that good negative pressure to draw in air. If we don't, we're going to have what's referred to, we can have what's called a flail segment. So when we talk about flail segments, we're talking about 2 or more ribs being broken in 2 or more places. Now, in most people, it's really hard to really find a flail segment. Now, on palpation, we may feel some crepitus, but what we would have to do is we'd actually have to get down and really look at the area that's has the possibility of a flail segment. So we know that when we breathe in, we cause a negative pressure, and so we would expect this flail segment to be drawn in, sucked in. And again, there's no integrity here. It's just free-floating bone. So when the patient exhales that positive pressure, the flail segment will actually kind of push out. Again, this is really hard to find, especially people that have a lot of fat around the chest. So you really have to really look at that. And we normally stabilize this with just a pillow. So let's just kind of review a little bit of stuff here. Tension pneumothorax results from ongoing air accumulation in the pleural space. It increases the pressure in the chest, and it's commonly caused by blunt injury where a fractured rib lacerates the lung or even the bronchus. Now, hemothorax, we're seeing here where we're getting a laceration of the lung itself or one of the vessels, and it starts filling up with blood. Again, if the patient is allowed to sit up, the blood will, by gravity, go down towards the bottom of the thoracic cavity and allow some ventilation of the lung tissue itself. We can have both hemo and pneumothorax. Again, in a hemothorax, blood collects in the pleural space from bleeding around the rib cage or from a lung or great vessel. Now, remember, there are vessels on the underside of each individual rib that can become torn in case of a trauma, as well as vessels, small capillaries in the lungs that could be affected, or again, the great vessels. Our pre-hospital treatment, there's nothing you can do to control this kind of breathing. Again, get the patient sitting up, allow gravity to help pull that blood down to the bottom of the thoracic cavity, allows the top of the lung to hopefully expand a bit and provide a rapid transport. And the presence of both air and blood in the pleural space, that's referred to as a hemopneumothorax, and that could be quite serious. In fact, that the pneumothorax has a big tendency of causing a tension, probably more so than just the hemothorax itself. Now, cardiac tamponade. Now, you have a protective layer around the pericardium. This is where the heart cannot adequately pump the blood. So the only pre-hospital treatment we have is to support ventilation and provide transport. So we have the pericardium on the outside here. Now the pericardium, there is a small space, and this is kind of accentuated just for demonstration, but the pericardium is very close to the heart muscle itself, the cardium, and it has a lubricating fluid in between them, and it kind of seals in between. This is sealed, it's a space, but we call it a potential space. So if there's any damage that happens, especially if the heart is damaged and there's bleeding between the heart muscle and the pericardium itself, the pericardium only has so much room to stretch. It does stretch a little bit, but once it starts stretching, it can't stretch anymore. The accumulation of fluid will then push against the heart, and like the effects the tension pneumothorax has on the heart, the pericardial tamponade has on the heart. So you're going to have a rapid heartbeat, you're going to have that narrowing of pulse pressures. Again, what has to be done in this case is there's a needle has to be put up into the pericardial sac and the blood drawn off, and it'll allow the blood to or the heart to have room to beat again. So we see this not only in trauma, but we can also see it in a medical condition called pericarditis. And pericarditis is a medical condition in which pus can start building up in the pericardial space, and eventually, with enough of it, cause a cardiac tamponade, and that can be quite serious. So in a pulmonary contusion, we see here they have a really nice look at normal lung tissue that isn't, blood filled, and the pulmonary contusion tissue where you see is kind of bloody. And so we have that area there. Keep in mind, with this injury, we can't have that gas exchange. So suspect cardiac contusion in a patient with a flail chest. It's where the pulmonary alveoli become filled with blood, leading to hypoxia. This is a patient where we need to provide oxygen and, if necessary, positive pressure ventilation. Dramatic asphyxia, and this is a little over accentuated. I love this particular slide because for some reason the guy is holding a martini glass. But it's characterized by distended neck veins. So again, the mechanism of injury is where the chest itself will take a tremendous pressure blunt trauma. So this is a person that would have, one that I've seen was a woman got stuck under her car. She got out to get something. She had it in neutral, and what happened was the car rolled over her as she was getting out, and she was stuck under it. And so she had these signs is, again, the distended neck veins, cyanosis to the face and neck, and hemorrhages to the scleras of the eye. Now this is, a lot deeper. It could be simple petechiae, which is kind of the dots, but it could actually be just really gross redness from the burst blood vessels inside the scleras, the whites of the eyes. So here's a photograph of a patient that had suffered a traumatic asphyxia. We can't see his eyes, and it's really difficult to see his neck veins. But again, you can see where he had a big pressure blunt trauma to the chest. You see some areas down here where the blood has been pushed out into the dermis, and if there's a little better picture, we'd actually see the distended neck veins, the redness of the face and chest, all of it indicative of that traumatic asphyxia. Now, while I'm right here, I want to discuss another thing, is subcutaneous emphysema. Now, we see subcutaneous emphysema in anytime you have a blunt trauma to the chest that actually would cause a pneumothorax. So it's like, if you will, you taking a paper sack, blowing it up, and then popping it. That's pushing the air through the thoracic cavity and up into, pushing air up into the subcutaneous layers. So the dermis, the epidermis, just below that. It could also happen when they have a tension pneumothorax. They get enough pressure, the air pops through and goes up under the skin. And it feels like, if you will, if you take Rice Krispies and put them in a plastic sandwich bag and feel them. And that's kind of the feeling that you get. And I've noticed that in a lot of cases, you're going to feel subcutaneous emphysema up in the axillary areas, up under the arms, and up along the top here of the chest. These are two areas where there's some weakening of the thoracic cavity where the air can breach through. So, back to traumatic asphyxia. That sudden severe compression of the chest suggests an underlying injury to the heart and possibly a pulmonary contusion. In this case, these are patients that we provide ventilatory support with oxygen, monitor their vitals during immediate transport. Again, these are patients that you may have to do CPR on. Make sure you have enough crew members with you. And if you have mechanical CPR devices, think ahead early. Get them into the CPR device. Don't turn it on, but just prepare for the possible need. And we're wrapping this up with myocardial contusion. Again, this is where we would have a bruising of the cardiac muscle itself. Now, the danger in myocardial contusion is this area becomes ineffective. So it's kind of like what we would see in a myocardial infarction, that type of injury to the heart. So will this get better? A lot of times these do get better as opposed to the necrotic tissue that we see in myocardial infarction, late stage myocardial infarction. So again, this isn't working well enough depending on where the injury is, and you're not going to get the ability to pump. So we're going to see the heart try to compensate by beating faster, but not as effective, and we may have a lower blood pressure, hypotension. So in our blunt myocardial injury, the heart may be able to maintain adequate blood pressure. Suspected in all cases of severe blunt injury to the chest, we have to make sure, as with all of these, monitor pulse and blood pressure, provide oxygen, and rapid transport. Again, chest injuries are a cut to cure proposition, and they need to go to surgery. We see commotio cordis in an injury by a sudden direct blow to the chest during a critical portion of the heartbeat. Again, this is right where at repolarization of the ventricles. It may result in immediate cardiac arrest, and ventricular fibrillation in this case responds very well, but the defibrillation has to be within 2 minutes of the injury. That's why it's really kind of a good idea that defibrillators are in places where this can happen. So this slide shows a little bit clearer that critical point where the heart is repolarizing. Now, right here in the T wave is where the ventricles are repolarizing, getting ready to beat again. Again, this is the electrical system of the heart. So when we have a blow to the chest, it's like almost a mini defibrillation. And you've probably heard of precordial thump, where we whack the patient on the chest. That's kind of the same thing. Only this is in a good, healthy heart. So it's at this critical junction of heart repolarization that if they get a blunt injury to the chest, it can knock the patient into ventricular fibrillation, cardiac arrest. So what are some of the occasions we would see this? We see it primarily, actually, in Little League Baseball. And you'll see in some Little League Baseball teams that they'll actually have a chest protector now for the pitcher. We can also see it, of course, lacrosse and hockey, and occasionally in the martial arts. So, and keep in mind, this is a 20 millisecond window that this happens in. So, and like I said, in the martial arts, that's where we come into the 5-point palm exploding heart technique. So, be just aware of that. Let's talk about the laceration of the great vessels. Again, this may result in rapid fatal hemorrhaging. Again, these vessels are incredibly large. The great vessels we're talking about, of course, are the superior and inferior vena cava, the aorta, the pulmonary arteries that go up into the lungs on both sides. We kind of talk about the pulmonary veins as being part of the great vessels. I think they're just merely above average. But if these are torn, any of these can produce a tremendous amount of bleeding and a fatal hemorrhage. So our pre-hospital treatment is, again, considered early. You may have to do cardiopulmonary resuscitation, ventilatory support, immediate transport, and monitor for shock and changes in vital signs. So be ready to do CPR, patient on oxygen. And again, think about mechanism of injury and high index of suspicion for these injuries.